Right, so chapter 15, medical overview. All right, so patients who need EMS assistance, they generally have experienced a medical emergency, a trauma emergency, or both. We know that trauma emergencies involve injuries resulting from physical forces applied to the body, while medical emergencies involve illnesses or conditions caused by disease. It is very important to remember that patients may have a combination of medical and trauma conditions. For example, you may be called to the scene of an accident, sorry, and your patient has a traumatic injury, for example, a laceration to the forehead from hitting up in the windshield. And that's a traumatic emergency, a trauma emergency. But the patient may have met into the motor vehicle accident because he or she is a diabetic and went hypoglycemic. And as a result, it resulted in the accident. All right, so there are different types of medical emergencies. You have respiratory emergencies. That's when the patient is having trouble breathing or when the amount of oxygen supplied to the body tissues is inadequate. You have also cardiovascular emergencies that are caused by conditions affecting the circulatory system. And we see this a lot during congestive heart failure or myocardial infarction. Neurologic emergencies, those that involve the brain, like seizures, fainting, gastrointestinal conditions, including appendicitis, diverticulitis, and so on. We also have urologic emergencies like kidney stones. We have endocrine emergencies, the most common being diabetes mellitus, hematologic emergencies, which may be as a result of sickle cell anemia or blood clotting disorders such as hemophilia. You also have immunologic emergencies, which involves the body's response to foreign, or the body's immune response to foreign substances, such as your anaphylaxis reaction, hay fever, allergic reactions like that, toxicologic emergencies, including poisoning and substance abuse. Bear in mind, though, that some medical emergencies are also caused by behavioral or psychological problems, and it may be difficult to deal with these patients because they don't present with typical signs and symptoms. There are also gynecologic emergencies, which are those involving the female reproductive organs. So here are the types of medical emergencies and the related conditions as we went through respiratory, meaning asthma, emphysema, chronic bronchitis. We'll go through all of these. Well, we'll go through most of the respiratory ones today. And of course, we spoke about cardiovascular ones and so forth, seizures, stroke, sickle cell. Sickle cell disease is very prevalent in Jamaica under hematologic emergencies. We'll discuss anaphylactic reactions. And of course, I think yesterday you guys touched on some of the gynecologic ones. All right, so the patient assessment, pretty similar to that the patient assessment during traumatic emergencies. but instead of focusing on the mechanism of injury, you actually focus on the nature of illness, as well as the symptoms patient is experiencing and the chief complaint. Right. During the assessment, you always should bear in mind that sometimes the patient may present with an injury that may distract you from other injuries or other important injuries or an underlying condition. For example, again, your patient may be a diabetic suffering hypoglycemia, but you're concentrating on that big laceration on the forehead as a result of the motor vehicle accident. So you have to be very careful that you don't have what is known as tunnel vision. That is when you focus on one aspect of a patient's condition and exclude the other aspects, which may be important in your treatment. It's important to establish an accurate medical history. You're going to use the dispatch information as your guide to your initial response, but do not lock yourself into the idea that that is what is happening to the patient solely. Right? See, we spoke about tunnel vision. Don't get locked into the idea. Yes, you're responding to a motor vehicle accident, but it may not be a trauma. It may be as a result, the motor vehicle accident may be as a result of a medical emergency like hypoglycemia. Right? Assessment may be difficult with uncooperative or hostile patients, but always maintain a professional, calm, non-judgmental demeanor at all times. We cannot go around either labeling patients or displaying personal biases like, hey, I don't want to treat this person because they're of a particular ethnic background. No, every patient is equal in our eyes. Refrain too from labeling patients. A patient may always initiate EMS because they're intoxicated, and so because of that they have altered mental status. But suppose this last call the patient is calling because the altered mental status is because they fell and bumped the head. So never assume that a frequent caller is calling about the same thing all the time. All right, so the the scene size up in trauma, you ensure that the scene is safe. So make sure that the scene is safe. Use standard precaution, especially during this COVID time. We have to be careful. You have to use your gloves, your N95 mask at a minimum, your PPEs. Determine the number of patients and whether or not you need additional help. Right, so determine the nature of illness. When you determine the nature of illness, what could be causing this? So patient is having difficulty breathing. So it's a respiratory illness. So this helps you this provides you with an index of suspicion for different types of serious or underlying illnesses. The index of suspicion is your awareness and concern for potentially serious underlying and unseen injuries or illnesses. So if it's the nature of illness, patient has difficulty breathing, respiratory condition. So you say, oh, it could possibly be X, Y, and Z. Is it an asthma attack? Right, so right then and there, your index of suspicion. All right, so as you approach a medical patient, you should develop a general impression of his or her condition. You perform a rapid examination of the patient to identify life threats. Visual clues include like unconsciousness, severe bleeding, or extreme difficulty breathing. After that, you quickly determine the patient's level of consciousness. Sorry, and you do this using the AVPU scale. If the patient is alert, you and speaking, then you know that the airway is patent. If the patient is unconscious as you approach, then you try to see if you can get a response by verbal stimulation. Hello, hi. Speak to the patient while gently touching the patient. If the patient does not respond to verbal stimulation, then you move on to P, which is painful stimuli, which is either you pinch the patient's ear or you use the trapezius squeeze test, which is pinching the muscle that run alongside the side of the neck to the shoulders to see whether or not the patient elicits a painful response. If there is no response, then you know that the patient is unresponsive, and at this time you quickly continue the assessment. In a conscious patient, you ensure that the airway is open and that they're breathing adequately. You check the respiratory rate, which in an adult patient should be between 12 to 20. In a child should be between 15 to 30, and an infant 25 to 50 breaths per minute. The depth. Are you seeing sufficient rise and fall of the chest? Right? And that will indicate the tidal volume. Is there enough air passing in and out of the lungs? And the quality of respiration. Is there any breath sounds, adventitious breath sounds like wheezing, gurgling, crackles, rhonchi, right? For unconscious patients, you make sure that the airway is open using the proper technique for their conditions. So is it the head tilt chin lift, or if there is suspected spinal injury, a jaw thrust maneuver? All right, you're gonna consider applying oxygen for patients with difficulty breathing and when the oxygen saturation is less than 94%. You could let your partner administer oxygen as you continue your assessment. For unconscious patients, they may need airway adjuncts and ventilatory assistance with a bag valve mask. We apply oxygen to patients in shock, with difficulty breathing, or when low oxygen saturations are measured. Normally, we do low flow oxygen with patients with saturations between 90 to 93% and high flow for those less than 90%. You quickly assess the circulation in the conscious patient by checking the radial pulse and observing the patient's skin color, temperature, and condition. For the unconscious adult patient, you assess circulation at the carotid artery. And of course, you know the child, you do the brachial artery, right, in the arm. All right, so transport decision. Patients in need of rapid transport are those that are unconscious or have altered mental status. Airway or breathing problems. If they have airway or breathing problems, then you need to consider rapid transport, load and go patient, not stay and play. Obvious circulation problems such as severe bleeding or signs of shock. For history taking, this may be the only way to determine what the problem is or what's causing it. It's very important to get a thorough history from the patient and our family members, friends, or bystanders who may have pertinent information. Sorry. Family members may be able to help us to know what medication the patient is on, as well as whether or not the patient had any previous injury before. You can probably ask them about whether or not anything like this has ever happened, you know. Also, in terms of family members will also help you to ascertain many critical information, especially if the patient is unconscious or having difficulty breathing and can't talk a lot. For the unconscious patient, however, you may have to become a detective. You have to survey the scene for the medical containers. Is this a medication that's used for asthma or the medical devices? This person has a spacer, possibly an asthmatic. You obtain a sample history and use the QPRST mnemonic, especially if there's difficulty breathing along with pain. Record any allergies, medical conditions, and medications. Some patients take numerous medications, so as we discussed before, take the medications with you to the emergency room. The secondary assessment, it may occur on scene or en route to the emergency department. In some cases, it's not done at all. It may be a situation where you're trying to resolve so much life threats that you don't have time to do a secondary assessment, as well as the time, the distance of the facility from the scene of the incident. Physical examination. All conscious patients should undergo a limited or detailed physical examination. If a patient is having difficulty breathing, you do all the ABCs again and so forth. Physically examine patient. Sound the chest, apply your devices at this time, like your pulse oximeter and so forth. For unconscious patients, you have to perform a secondary assessment of the entire body. Head to toe examination is needed. The physical examination, I know that you guys went through some of this already. Examine the head, scalp, and face. Go down to the neck and examine it closely. Looking out for jugular vein distension in the neck area. Deviated trachea, you'll know what is happening based on these. Assess the chest and abdomen, palpate the legs and arms, examine the patient's back. You also collect a complete set of vitals. So you access for pulse rate. The pulse rate, of course, should be between 60 to 90 beats per minute. The quality of the pulse, is it weak or thready? Is it strong? Is it bounding? Regularity, that is it consistent or is it irregular? If it's irregular, then right then and there, you can determine that this incident may be because of a cardiac problem. Identify the rate, quality, and regularity of respiration. Went through that already. Obtain an initial blood pressure. You do this with a manual sphygmomanometer or blood pressure machine first, and then subsequent readings you can use with the digital blood pressure machine. Consider obtaining a blood glucose level and a pulse oximetry reading. And of course, you know that for the blood glucose level, normal fasting blood glucose is between 3 to 6 millimoles per liter. And of course, the pulse oximetry reading between 95 to 99, normal. The reassessment is performed once the assessment and treatment have been completed. It begins and continues throughout transport. You reassess their interventions. Are they working? If they're not working, what do I need to do? And of course, you document any developed changes. Most medical emergencies require a level of treatment that is beyond that is available in the pre-hospital setting. For example, a patient may be experiencing a heart attack, so they may require advanced testing. Suppose it's a situation where they need to do a troponin eye test to find out if they're experiencing the heart attack. They may have a blockage that needs to be cleared in a cath lab, stuff like that. So it may be beyond the scope of an EMT to administer medication to a patient, right? So suppose they need clot busters. We don't have that in the pre-hospital settings. The scene time, this may be longer for medical patients than for trauma patients. You need to gather, because we need to gather as much information as possible. But bear in mind though, critical patients always need rapid transport, so we wouldn't delay with a critically ill patient. Type of transport. Life-threatening conditions, we require light and siren. Non-life-threatening conditions, which are considered non-life-threatening, you consider non-emergency transport. So without lights and siren. And then this makes sense because it's only a few minutes delayed when compared to when lights and siren are used. The modes of transport ultimately come in one of two categories, ground or air. For ground transport, EMS units are generally staffed with EMTs and paramedics. And for air transport, EMS units are generally staffed by critical care transport professionals and paramedics. So we normally select the destination based on the closest hospital to the scene. Some patients, though, will benefit from going to another hospital capable of handling his or her particular condition. For example, if your patient is experiencing, say for example, a difficulty breathing as a result of pulmonary edema, and the patient has end-stage renal failure that requires dialysis. We know that the patient has a fluid overload and that's why they're breathing abnormally. We wouldn't say transport them to Andrews. Andrews don't have a dialysis unit. So instead we'll take them to University Hospital. Same thing with somebody who is experiencing a stroke. In the US, you have particular institutions that deal with your stroke victims. So in order to save time and to improve the prognosis of the patient, we would transport to that facility, even though it may not be the nearest facility at the time. All right, so for infectious disease, we have to approach the patient with an infectious disease like any other patient. We perform the scene size up, we take standard precaution and complete the primary assessment. We gather the patient history using the OPQRST to elaborate on the patient's chief complaint. We obtain a sample history and a set of baseline vital signs. We pay particular attention to medications and the event leading up to today's problem. Ask whether the patient has recently traveled or come in contact with somebody who has traveled. All right, so general management principles. Focus on any life-threatening conditions identified in the primary assessment. We have to be empathetic. Sometimes these patients are very frightened. We also place the patient in a position of comfort on the stretcher and keep them warm. We use standard precaution. Always follow your agency's exposure control plan in cleaning equipment and properly discard of any disposable supplies and wash linens. In fact, I recently came up an article that actually spoke about COVID-19 and EMS providers, and that's it. Even the driver of the ambulance, if they're going into the ambulance prior to doing a procedure on scene, then they have to take off their PPE before entering the ambulance to drive off, because especially if the two compartments are not isolated from each other. And of course, cleaning of the ambulance equipment after the patient has been transferred to the emergency department is very important. All right, an epidemic. An epidemic is when new cases of a disease in the human population substantially exceed what is expected. Of late in the news, we're hearing about the monkeypox, where they're having an epidemic in, for example, the UK, seeing much more cases than what is usual. And of course, all of us know about pandemics. We have heard about COVID-19 for the past 2.5 years, which is a disease outbreak that occurs on a global scale. All right, so we're going to talk about influenza. Influenza, persons that have chronic medical conditions, compromised immune system, the very young and the very old are susceptible to complications of influenza. It's transmitted by direct contact with nasal secretions and aerolized droplets from coughing and sneezing by infected persons. All right, so for disease that can be passed on by the respiratory route, we always should wear PPEs, which include gloves, your eye protection, and your N95 mask at a minimum. You wash your hands frequently. Place a surgical mask on patients with suspected or confirmed respiratory disease. You wear your HEPA respirator or N95 mask during aerosol generating procedures, such as when you're suctioning the airways, performing CPR, or assisting with endotracheal intubation. It's important that EMTs actually get immunized against influenza. Annual influenza immunization is important. And usually the vaccination for influenza, it's a little different every year. So every year you need your shots. Herpes simplex. This is a common virus strain that's carried by humans. Symptomatic infection causes eruptions of tiny fluid-filled blisters called vesicles that appears on the lips or on the genitals. Sometimes in Jamaica we call it night fever when it comes on the lips. It can cause more serious illnesses like pneumonia and meningitis in the very young, very old, and immunocompromised patients. The primary mode of infection is through close personal contact, so standard precautions are generally sufficient to prevent the spread to and from healthcare workers. For HIV infection, EMTs face a risk of exposure to the virus that causes AIDS on a regular basis. AIDS can still be fatal. It doesn't have a vaccine, but with treatment, patients can expect a near normal lifespan. HIV is a potential hazard only when deposited on mucous membrane or directly into the bloodstream. It is really not easily transmitted in the work setting, but your risk of infection is limited really to exposure to an infected person's blood or body fluid. Suppose the blood splashes into your eyes, or you may become exposed if, for example, you respond to a motor vehicle accident, a piece of the glass that cut the person, and that piece with the blood on it has also cut you, right? So that means you've been exposed. Many patients with HIV show no symptoms. So you're supposed to always wear the proper type of gloves. If the glove becomes torn, then change it, put on another glove. Take great care in handling and properly disposing needles and other sharp objects. For example, if you respond to a scene with a drug, like a drug addict has overdosed, then those sharps, you need to be very careful that those needles are disposed properly. Cover any open wound that you have whenever you're on the job. If you think that a patient's blood have entered your system, then you seek medical advice as soon as possible and you notify your infectious disease officer. So normally for occupational exposure, then you go on a combination of antiretroviral drugs, sometimes for 1 month, 1 or 2 months at a time. Hepatitis. Hepatitis really refers to inflammation and often infection of the liver. Can be caused by a number of different viruses and toxins. There is no way to tell which hepatitis patients are contagious. Hepatitis A can be transmitted only from a patient who has an acute infection, where hepatitis B and C are transmitted from long-term carriers who have no signs of illness. And of course, a carrier is a person in whom an infectious organism has taken up permanent residence and may or may not be causing the active disease. Hepatitis A is transmitted via the oral route through oral fecal contamination. And let me just change the slide so you can get an appreciation of it. I'm not sure if you, wow, not sure if you can see the slide, but it shows the different types of hepatitis, A, B, C, and D. Hepatitis B is far more contagious than HIV, so we have to be careful. Vaccination with hepatitis B vaccine is highly recommended for the EMT. And if you see here, you see that hepatitis B is transmitted via blood and sexual contact, as well as saliva, urine, and breast milk. C is by blood and sexual contact, and D is by blood and sexual contact. So only A is by the fecal oral route or infected food. In fact, some restaurants, when you go, even water with ice or seafoods, if a person in there has the active form of the infection and you eat or drink ice water from them, you can contract this. For hepatitis A, there is no chronic condition, but for B, C, and D, it can cause chronic infection and damage to the liver. There are also some drugs, their use or misuse, as well as alcohol, can cause hepatitis. So these are toxin-induced. This would be toxin-induced hepatitis. Meningitis. Meningitis is inflammation of the meningeal covering of the brain and spinal cord. Most forms of meningitis, it's not contagious, but one form called meningococcal meningitis is highly contagious. You have to take standard precaution using gloves and a mask to prevent the patient's secretion from getting into your nose and mouth. Vaccines are rarely used. Meningitis can be treated in the emergency department with antibiotics. After treating a patient with meningitis, you contact your employer health representative. Tuberculosis. Most infected patients are well most of the time. A chronic mycobacterial disease that usually strikes the lungs. The disease that occurs shortly after the infection is known as primary tuberculosis. But the reactive tuberculosis is common and can be much more difficult to treat. So subsequent infections can be much more difficult to treat. Patients who produce the highest risk, they are the ones that always have a cough. So there's a characteristic cough. You should consider respiratory tuberculosis to be the only contagious form because it is the only one that's spread by airborne transmission. It's spread by the droplets that are in the air, suspended in the air. They can be suspended for a long time in the air. So your N95 or EPA mask is required in order to prevent transmission. Right? So absolute protection from the infection it doesn't exist. In fact, about 1/3 of the world's population is infected with tuberculosis. The mechanism of transmission is not very efficient. Since it is only confined to closed space, like in your prisons, in persons that large amount of persons living in the same area. That is how it is transmitted. It's transmitted. Once the place is given some sort of oxygen or what Jamaica would say air out, then the virus tends to dissipate in the air and is not readily spread. Whooping cough. This is also known as pertussis. Whooping cough is an airborne disease caused by a bacteria that mostly affect children younger than 6 years old. Symptoms include fever and a whoop sound that occurs when inhaling after the coughing attack. The best way to prevent exposure is to be vaccinated with the DPT or Tdap. You can also place a mask on the patient and on yourself. Methicillin-resistant Staphylococcus aureus. This is a bacterium that causes infection and is very resistant to many antibiotics. It is transmitted in the healthcare system from patient to patient by unwashed hands of healthcare providers. Very sad. It is resistant, as I said, to many antibiotics. So usually, if a patient has MRSA, then a culture and sensitivity test is done. The results are, the sample is sent to the lab. But in the meantime, you would treat the patient empirically or broadly to try to cover as much of the bacteria that you suspect is present. When the tests come back from the lab, then the antibiotics can become more specific. Very hard to treat sometimes in the healthcare system. Factors that increase the risk for developing MRSA include antibiotic therapy. So if you have been on a long-standing antibiotic therapy, like your patients with chronic the inflammation of the prostate, if you have prolonged hospital stays, if you're in like the intensive care unit or burn unit where you're severely immunocompromised, then of course this can happen. Exposure to an infected patient, The incubation period, though, for MRSA appears to be between 5 and 45 days. It results in soft tissue infections. Signs and symptoms include localized skin abscesses and sepsis in older patients. Sepsis or septic shock, right? Very fatal. All right, so COVID-19 is the next infectious disease. We all know about it. What happens is that it originated in Wuhan, China. It actually spread very rapidly, infecting millions. Even though this slide is saying killing hundreds of thousands, the last count was over 6 million persons worldwide have died from this virus. Controlling the virus means that you have to social distance. Symptoms include fever, cough, shortness of breath that appears 2 to 14 days after exposure. The harmful thing with this is that a lot of patients are asymptomatic, and the virus really is detrimental to persons with chronic illnesses like diabetes, end-stage renal failure, also the very old persons that may be immunocompromised. Your HIV patients too, they are more susceptible to the detrimental effects of this virus. There are actually different phases of the virus too that have been identified. In the last phase or the fourth phase of the virus, this is the most damaging phase of the virus, in that what happens is that the lungs become inflamed. Pneumonia usually results from the virus because fluid and pus fills up the alveoli. Additionally, there is pulmonary edema because and this causes the walls of the alveoli to separate from the capillaries. So gaseous exchange is affected. And when this happens, the patient becomes hypoxic. There is low oxygen levels. Damage to the lung can be so severe that there's scar tissues that form during the last phase of this attack, because what happens too is something called a cytokinase storm, where the body's natural immune system, it overproduces an immune substance called cytokines, and this can actually damage the lung tissues. So here is it. Patient is already having pneumonia, having difficulty exchanging gas, oxygen, and now the lung tissues are being damaged. When the patients become intubated and are put on a ventilator, usually the prognosis is poor, and sometimes these patients die. All right. MERS-CoV. This is a Middle East respiratory syndrome coronavirus. It was actually thought to transfer from camels to humans, and the first human case was discovered in 2012 in Saudi Arabia. There is no cure or vaccine for this virus at present, so you put a surgical mask on the patient if MERS-CoV is suspected. All right, Ebola. Don't know if you guys are old enough to remember the outbreak, like, well, 2014. But I don't know if you guys were following it up at the time. But what happened is that in West Africa, there was an outbreak. A lot of persons died. The incubation period is 6 to 12 days. Persons became severely dehydrated, and that is what killed a lot of them. The infection spreads by being in contact with the body fluids of persons that are infected or even the dead. So symptoms may not appear for as long as 21 days after infection. The fatality rate can be as high as 70% if treatment in an ICU is not initiated when it should be. All right, so for travel medicine, we must be aware of travel-acquired infections when assessing a patient who has recently traveled outside of the country. Patients can present with a variety of symptoms including fever, cough, vomiting, bloody diarrhea, body aches, and rashes. When you encounter an ill patient with a recent travel history, you have to place a mask on the patient and gather as much information as possible. Right, it's important to ask certain questions like, where did you travel? Did you receive any vaccination before your trip? Were you exposed to any infectious diseases? Is there anyone else in your travel party who is sick? What type of food did you eat? What was your source of drinking water? All right. So assessment and treatment of medical patients can be challenging and interesting because of the nature of medical conditions. The condition of a patient may not be as apparent as in a trauma patient, and the treatment may not be as straightforward. Patients sometimes have more than one isolated problem, so we should always bear this in mind.